A lot of fun doing this. And one of the things that I spend a lot of time doing with Matt Harker, who's an incredible operations lead for what we're calling the Evidence Hub, is trying to create this cross-cutting, boundary-spanning infrastructure. And you see, we're talking about health systems, School of Medicine, professional schools, and arts and sciences. And we're so pleased to have Valerie Ashby, the Dean of Arts and Sciences, here today. And we want to do so much more with them as well. And the point of boundary spanning infrastructure is that there are incredible things happening at Duke. But in the health policy realm, we believe if we can connect ourselves better in better, more interdisciplinary focused teams, we can do a better job of creating the answers that the country really needs to reform the health system. There are many things that the Evidence Hub will do. I'm just going to give you an example. One project that you're going to hear about a little later today, this Center for Medicare and Medicaid Innovation Palliative Care Award, just to give you a hint of what it means to be boundary-spanning infrastructure. Leslie Curtis in Pragmatic Health Services Research, and now the Center for Population Health, she's an incredible resource for Medicare claims. That's the basis of this project. Eric Huang in DTRI and Shelley Rusinkovich are creating this new analytics side infrastructure to answer questions in a better way. Jerry Ryder in Stats Department on this same project is giving us new perspectives on how to bring Bayesian notions of non-experimental inference into asking these research questions that will never, ever be answered in a clinical trial. Arif Kamal in Duke Cancer Institute, an oncologist who's a palliative care expert, is an expert in the measurement of quality of palliative care. And he's overseen the development of QDAC, which is a data infrastructure system to measure quality that Duke has undertaken. You've got to have the quality joined along with the cost to be able to say something about value. These are just examples. There are many more that could be given, but that's just one project. And the point is, we could have done something pretty good in any of those buckets, but we could do so much better only by joining everyone together. And so one thing I would say is there's some projects, Arnold Foundation project on evaluations, CMMI, that are a part of the Evidence Hub, but when we will have really arrived is when there's somebody who's not here today that none of us even really know about, who we will help get their first R01. We will help them get tenure. We will see them bring about the evidence that the country needs, where we're not only doing the work that the people in this room already have funded, but we're helping get better, more important work funded as well. So now I'm going to turn it over to Jeff, who is an internist, who is going to give us a deeper dive on Medicare claims, which is a key resource.
Thank you, Don. It's a pleasure and an honor to be here today. Prior to coming back to Duke, I was at CMS for a few years working in the Innovation Center. And I think as others have commented, we know that this is a historic time. Our policy leaders are really making a lot of changes to the financing and delivery of the healthcare system. Having been in that role, I recognize the challenges of navigating these treacherous waters while a sort of chorus of stakeholders are screaming conflicting directions, many of whom are saying go back in the other direction, which just isn't an option. I think I was most impressed at the audience, those who were able to bring data and objectivity were given. And I think we have a real opportunity to elevate and have our voices heard by not only bringing sort of the breadth and depth of expertise, but also our culture of scientific integrity and value of objective evidence. So of course, being able to do that and being able to produce evidence on a timely basis means we need to have data. Okay, sorry. If we could go to the next slide. So Duke, and particularly the DCRI, has a long history of working with data, particularly Medicare claims data, and we have a number of resources that we will hopefully be able to reuse for these purposes. I wanted to just highlight one example. This middle bucket here is a data set that we've been moving forward with support from Duke Margolis, as well as the Center for Population Health Sciences. And what we're acquiring is data for all Medicare beneficiaries who are participating in the Medicare Shared Savings Program, which is far and away Medicare's largest alternative payment model, or the Accountable Care Organization Program. Duke's a participant in this. Just to give an example of the multiple uses for this type of data, one, we can certainly answer questions that will help policymakers refine this important program and other similar programs so that they're more effective in achieving the goals of high-value care. Secondly, because accountable care organizations are really small or fairly large populations and associated providers, we'll be able to use these data to look across systems of care and understand how people are able to effectively deliver care for a wide variety of issues. It could range from end-of-life care to even delivering effective preventive medicine for cardiovascular disease. So we'll be able to generate evidence that's useful for policymakers and providers alike, and it may even lead to new focused payment models. And then finally, we're going to be using our analytic expertise, and we're going to be creating a set of tools that will be useful to frontline clinicians, health system managers, and basically developing and testing their own innovative ideas. And so as we move forward, as we mentioned, we think there will be a lot of other opportunities to continue to build our data stores in the public and private sector, moving beyond claims data. But we think that this will be a key opportunity that will produce a lot of effective output. I think I'm handing off to George next.
Yep.
So I'm George Cheeley, and will echo Jeff's comments about the opportunity and the privilege to be able to speak to this group. I also had to smile when Jeff mentioned that he spent some time at CMS. If someone can cue up the next slide, have been working on clinical delivery redesign for the last 4 years or so, and really cut my teeth talking to Jeff shortly after he left Duke about some of the pluses and minuses of the bundled payments for care improvement pilot. Just in a brief synopsis for those who are a little less familiar with what we do, we've been working with physician and nursing leaders to bring together multidisciplinary teams really tasked with improving outcomes for patients and identifying where waste exists in the system. And our methodology to identify projects is really focused internally as we've gotten our legs underneath us and our feet wet. And around the time that we've been re-examining how we pick teams, the Margolis Center has fortunately come to fruition, and it represents a tremendous opportunity for us as an internal team and for us as an organization to really have a bidirectional conversation about both salient policy topics and how we might translate those on the operational side, and then also to really share some lessons about the trials and tribulations of change. I'm struck by the fact that many of the physicians in the room have worked with us, and I can say, and I suspect resonates with many of you who have tried to do something new and different, we've learned a lot more from our missteps than we have from our steps forward. And I think to the extent that we are leading the way, we have a great opportunity to better empower the country and to better empower the places that need to make changes with some of those initial lessons to make changes easier. I'm coming back from Las Vegas, where I was talking with colleagues at the Healthcare Financial Management Association meeting, and the most innovative component of the presenters there really focused on the fact that clinicians needed to work with financiers to be able to drive down cost in healthcare. And I think for most of us in the room, that's a concept about as innovative as water being wet. And so I just view that as a tremendous opportunity for us to be vocal at a national stage and really share what we've learned to drive the conversation forward. Now I'm fortunate to hand over to one of the colleagues I've had the pleasure of working with, Brady Granger.
Thanks, George. The last time I followed George, we were being projected on a huge screen in Paris talking about Duke Care redesign, and I was the victim of a failed tooth implant. So with every word, my tooth was coming out of my mouth, and it was pretty scary. So I have been fortunate enough to work with a lot of people in this room, George being a key one, on these huge societal problems. And we began looking at what are the top societal issues among populations in North Carolina. We began somewhat on a large scale about 10 years ago with the Durham Health Innovations Grant. And that project was an attempt to take our population of North Carolina and look at 10 or Durham County, and identified 10 chronic illness populations that we felt like were the neediest. And from that initial planning grant, these next 4 projects spun out of that and were subsequently externally funded. But all of them addressed these top societal needs, the first 4 of which, interestingly, are behavior change related factors. The 5th one looks at what George and I had been working on, next blip, and that was how do health systems support patients with these 10 chronic illnesses? And then lastly, how do we pay for it? So as in this series of projects, we kind of took the top societal ills and tried to address them with a series of interventions. And these spanned a number of chronic illness populations, but all of them had a single common denominator, and that is we used big data to try and better understand who is the population at risk and what can we do to help them. Next slide. So before talking about what we measured, I think one of the things that we learned in the beginning is that we as the academic community were potentially at the greatest risk. Because as has been said before, we were sort of at risk for using the data to make academic observations about populations of people without ever really coming down from the tower to share the experience and shoulder the burden and walk alongside the people in our community that were struggling. And so throughout all of these series of projects, we measured things. We measured their behavior. We focused intensely on those top 4 items of behavioral change. We measured things about the built environment. We measured social determinants of health. And we partnered across counties, Cabarrus County being the location of the Murdoch Project, where we generated new population data, and then Durham County. And in addition, we partnered with counties outside of North Carolina in Mingo County, West Virginia, and Quitman County, Mississippi. So we focused on these high-risk areas of the Southeast to try and figure out how we could do a better job. And the project series was different because the patients, as I wanted to read what one patient said at the Community Advisory Board in April, this project, being a patient in the Durham Diabetes Coalition, was different. They didn't just come at me with all their knowledge. They didn't just give me information, give me papers, and tell me what to do. They came to my house. They adjusted to my schedule. They helped me set goals, and when I didn't achieve them, they helped me reset the goals. They helped me take small steps. They listened. They waited. So I think these projects were an example of using big data to meet patients where they are in the community and to help them and to help measure how we can do that better. So CMS is not excited about paying for a lot of listening time and a lot of home visit time. And so part of my excitement about working together in the Margolis Center is that we have been able to leverage the evidence from these projects to influence policy. And the slide now shows a couple of ways that we're doing that. The Aetna Foundation has sponsored a $1.5 million award for healthy communities, which Ashley Dunham has miraculously crafted into a beautiful document and submitted as a part of our work together. We'll find out in July about the award, but I think even without the award, there's been tremendous progress on the home front in our own community of Durham, where we now are working as a team with the health department, with the university, with NC Central University, to establish a certification program for community health workers, people who are affordable, who can sit and listen, and who can wait with patients while they try and achieve behavior changes that help all of us meet health goals for the next decade. Thanks.
Thanks very much. So we've talked about the opportunities nationally and locally, the same challenges and the same need for better evidence to address them is also true globally in both developed countries, even those with well-established social insurance systems and health insurance systems, as well as in developing countries. And Krishna is going to talk about our global focus here.
Great, thank you, Mark. And as Mark said, my name is Krishna Udaikumar. I'm a faculty member in Global Health and Medicine. I've had the pleasure of helping think about how we expand a lot of this work and connect it to what we've been doing to amplify our global impact. Again, by bringing a broader global lens, we hope that we can continue to have even more impact on health of patients and communities, and at the same time open up opportunities for bidirectional learning, understanding what other experiences have happened and how we can improve our own health and healthcare based on that. One of the ways that we've done this is to build on some very strong work that Mark and Andrea Toomey and others have done previously around the concepts of accountable care, and building on those principles to understand that the concept of accountable care holds universally everywhere in the world, not just in a U.S. context. And what you see on this slide are really the core principles of the policy orientations of accountable care, everything from understanding populations to developing performance measures and metrics, committing to continuous improvement, aligning payments and other incentives, and facilitating care coordination and transformation. One of the things that we've done to support lessons learned both for the international perspective as well as for U.S. policymakers, payers, and providers is to look around the world at examples where parts of these principles have been put into practice in high-quality ways. So everything from rural Nepal to urban Singapore, from the UK to Germany and the Netherlands, we've been able to start writing more case studies that go deeper in understanding what the success factors have been in putting principles of accountable care into practice, and then how these apply in bringing those principles back to the US. If we go to the next slide, what we're now trying to do is actually hold true to the mission of the Margolis Center, as Mark talked about, which is both developing evidence, but put evidence into practice. And so we are using this continuous cycle of continuing to refine the frameworks that we use to think about this work, and on the other side, to think about how we actually put these frameworks into application in the real world. So the triangle that you see or the pyramid on the left, so the accountable care policy principles I just spoke about really are the middle component of that, but understanding and refining how international and national and local policy context plays into the ability to use policy levers, and also understanding that those policy levers help facilitate innovation in the delivery and financing mechanism. So understanding from a healthcare organizational perspective what types of capabilities have to come into being and delivery innovations are able to scale are the types of frameworks we're now refining. And so we are also making sure that these frameworks hold not just for a US context, but hold true in terms of key principles from a global perspective. I talked about the examples from around the world of applying these accountable care principles and drawing from those lessons learned, which we've already started to do and started to see some significant interest from around the U.S., both in learning about, but being able to internalize these lessons learned into U.S.-based healthcare organizations. In terms of application, we have engaged either in small projects or at least conversations with public and private sector officials everywhere from Qatar to India to Singapore about how we can be a key resource and leader to bring these principles and lessons to facilitate both delivery and policy reform in those contexts. And finally, we are trying to link all of these in a congruous way to a lot of work we've been doing through Innovations in Healthcare, our nonprofit here, and other work through the Global Health Institute that's really been focused on delivery, innovation, and reform, and now adding to that the layer of understanding policy and financing and regulatory reforms to really move health and healthcare forward. And one of the mechanisms that you'll be hearing about soon that's going to give us a stronger platform to do this is the development of a new Global Health Innovation Center that will link very strongly the work of the Duke Margolis Center, the Global Health Institute, and our broader institutional efforts around health innovation.
Great. Thanks very much, Krishna. All right, so Greg Daniel is going to head up to the front while I make a quick transition here. So you've gotten a little bit of an overview of the work that we are trying to support around reforming healthcare delivery. And as you heard from people like Brady, this is not just important as it is to change the way that we treat chronic diseases and acute conditions in medical centers like Duke, but taking out to the community, influencing public health. Lots to build on at Duke there, both in terms of the local efforts in the community, in terms of efforts at the Duke healthcare system, and in terms of analytic capacity that we're bringing to bear both here and in collaboration with organizations around the country and really around the world. But going along with that is a tremendous opportunity here to bring innovations, to change the way that innovation works for biomedical technologies. So our second major work stream is about biomedical innovation, where there are still many opportunities to improve people's lives, but also very important policy changes that are needed to promote that valuable innovation and to make the new treatments accessible. So I'm going to turn over to Greg Daniel, who is the Deputy Director of the Center, based in Washington, D.C., again, part of this build-out of connecting Duke's resources to policymaking. And Greg's going to talk about the second work.